Very good evening, everyone. I am Arpita from the IGCP group, and I welcome you all to today's talk on the topic febrile seizures or meningitis diagnostic dilemma. And to address this topic, we are really honored to have with us Dr. Sanjay Chaudhary, sir. Sir is MBBS, MD, a distinguished senior consultant in the Department of Pediatrics at Fortis Healthcare, Jaipur. With his vast clinical experience and deep expertise in pediatric medicine, Sir has been instrumental in managing a wide range of childhood illness and guiding clinicians through complex diagnostic scenarios. In this session, Dr. Chaudhary sir will delve into one of the most challenging areas of pediatric practice, that is, differentiating between common febrile seizures and potentially life threatening meningitis. This session aims to provide practical insights and evidence based approaches to aid clinicians in making timely and accurate diagnosis in high stakes situations. Please join me in welcoming Dr. Sanjay Chaudhary, sir. Sir, with this introduction of yours, I would now request you to please start with the topic for today. Over to you, sir.
Thank you, Arpita. Thank you, Arpita, for letting me to discuss the common topics of pediatric concern over our group, IJCP, and it is I think one of the most forerunner group which is working in spreading the knowledge about various health issues among clinicians as well as uh, fellow citizens. So today our topic of discussion, as we have chosen, is seizures in children in presence of a febrile episode. So febrile seizure is one of the most dreadful situation uh, when a patient family members saw the child having some abnormal movement of upper limb, twitching of eyes, salivations, or frothing at mouth, or stiffening of body. So it is very frightening for the family, and it creates significant stress to the family and leads to variety of uh, thought process in themselves, having some bhoot pret or something medicine overdose, or they feel that it is reaction of something, or there is a snake bite, or uh, wide variety of thought process in presence of no means of knowledge what a seizure is. So once they have when we inform that it is a seizure and it is a activity of brain and it occurs commonly in children. So they initially they are apprehensive, they are not uh, appreciating the problem, but gradually they understand and they could differentiate between seizure with a febrile episode where the child is otherwise active and well, and non situation of meningitis or epilepsy where the problems are something in addition to seizure. There are lot many problems the family is perceiving. So our topic is febrile seizure, and it is one of the commonest neurological symptom in childhood. It occurs in in the common age group of 6 months to 6 years, and and uh, usually it occurs within first 24 hours of fever onset. Fever can, and this is one thing has to be reminded that fever can occur before the episode of fever in a febrile seizure as well as after the onset of seizure. So it is not essential that the fever is a predeceasing event followed by seizure. There can a seizure can be simultaneously felt as the fever, and sometimes fever comes after episode of seizure. But it is almost certain that it occurs in first 24 hours of onset of fever. Here, one thing has to be noted that any reason for fever, such as child may be having upper respiratory infection, sore throat, body rashes on the body, urine infection. So any kind of fever uh, of viral bacterial origin uh, can lead to increased chances of seizure, where the seizure threshold is reduced and the child has episode of seizure. So a febrile seizure without CNS infection is we call as simple febrile seizure, where we do not find any feature suggestive of infection to the brain, or there is no metabolic or electrolyte disturbance, or there is no history of seizure before this episode of febrile seizure. So the child do not have any history of afebrile seizure in the background, or there is no acute neurological insult such as injury to the brain or ear discharge in past, or some trauma. Uh, so we divide into two types, commonly into two, simple and complex. If the fever is an isolated event, there is no other CNS event along with the fever. There is URI, cough, cold, throat pain, ear discharge, that and associated with generalized tonic-clonic activity. Generalized tonic-clonic means uh, the movement of both upper limb as well as lower limb in a tonic and clonic fashion that lasted less than 15 minutes. That is, the activity of Caesar tonoclonic activity is absent when reached to the hospital or has been subsided at home. So, likely the not more than 15 minutes has elapsed, and and the Caesar frequency is not repeated in next 24 hours. So we call it as simple febrile seizure. What is in contrast to this simple febrile seizure? We call it as complex febrile seizure, where we do not find features suggestive of simple febrile seizures. The contrasting event is the seizure episode is more than 15 minutes and tend to recur within 24 or persist after 24, or the child is not recovered completely within 1 hour of seizure episode. So we divide this seizure into febrile or complex as soon as we saw the child with febrile seizure. There is one specific entity called febrile status epilepticus when the seizure time duration increases to 30 minutes or more. So, or there are series of seizure with no intervening recovery. That is, the child has not recovered after first season, and after a brief period, the child throws second episode, second set of tonic-clonic activity. Then we call it as febrile status epilepticus. What is a febrile seizure that I have discussed to you in between of seizure, febrile seizure? A seizure is an in an acute infectious illness where the child, the family haven't documented any fever episode, but there are the clinical features of pre and post event, duration of seizure activity, development milestone, normalcy of developmental milestones are consistent with febrile seizure. It is very common with such a febrile seizure is very common with gastroenteritis. There is a term called febrile seizure plus. Febrile seizure that continue past the usual age, that is more than 6 years of age, when we are expecting it febrile episodes to get resolved and or accompanied by a febrile general or febrile seizure. So there, the age of the child has passed more than 6 years. The child still having seizure episodes with or without fever, and the child is having accompanied a febrile generalized or focal seizures in addition to the febrile seizures. Then one more term of febrile seizure is genetic epilepsy with febrile seizure plus. So there is a background genetic epilepsy predisposition with the child having febrile seizure plus finding. Febrile seizure plus with a family history of febrile seizure, febrile seizure plus, or afebrile generalized or focal seizures. So once we have gone through this terminologies of febrile seizure, complex, simple febrile seizure plus, and with syndromic finding of genetic epilepsy. So once uh, we start evaluating this child, we go to the history when most of the time we go search the background. So we inquire about nature and duration of the convulsion and post-ictal phase. So what is the nature? It is generalized, focal, tonic, clonic or tonic-clonic, duration less than 15 minutes or more than 15 minutes, and post-ictal phase, that the post-ictal drowsiness or passage of urine or stool. So this is post-ictal phase. History of recent fever, ear discharge, burning micturition or dysuria, recent antibiotic therapy to the child, antipyretics given to the by the family in form of paracetamol, ibuprofen, or mefenamic acid, or any rescue convulsion, anticonvulsants have been administered to the child uh, by the nearest center where the family has taken the child to, or we inquire about what all vaccination the child has been given, as well as any recent vaccination history is there. Many a time the child has fever with after a DPT vaccine, so that child can also have seizure episode, which is not due to the vaccination content, but due to the raised temperature of the body. Past history of previous episode of febrile seizure, diagnosis of any positive diagnosis of epilepsy, and if there are any other neurological condition or diseases in the family or in the child. Family history of febrile seizure, epilepsy, or any neurological diseases, or history of neonatal NICU stay, or there is a significant developmental delay during past in, when they inquire about his neonatal or infancy period. What all we look for when we see the child physically, we we have to look for vitals. The child is stable or not. Airway, breathing, circulation. We have to check. Then we check about take a account of temperature, respiratory rate, heart rate. Uh, we ask for and look for the obvious focus of infection. If the child has running nose, nose block, snoring, ear discharge, bored rashes on the body, we take a weight and height of the child. We take a look for the features of raised intracranial pressure, such as raised IC, AF is bulging or not, or we check look for fundus if the ophthalmos scope is available. We look for the feature of suspected meningitis, such as bulging fontanelle, keeping if the child is keeping his neck retracted, or Karnitsa Brzezinski sign, or neck flexion, positive pain is there on flexion of neck. So they are signs suggestive of positive signs suggestive of meningitis. Although in infancy, if these signs are absent, we cannot positively or completely rule out meningitis. We follow the child, we follow the initial blood investigation as well if they are, suggest any significant bacterial infection or not. We look for neurocutaneous markers
Sir,
on the body. Yeah,
hello, sir. So
yeah.
kindly let me know when to change the slides.
Okay, okay. Because
Yes,
I
sir.
am changing my slide on my computer iPad. So
Yes,
I
sir.
could
But
not.
I'm
Yeah,
changing
yeah.
for the audience. They won't be able to see it if I don't change it, sir.
Oh, okay. I think I am on first, second, third, fourth,
Sir, let me know
fifth,
the heading. Diagnosis
fifth
clinical
slide. I am
exam.
on fifth slide.
What is the heading, sir?
Diagnosis, clinical examination.
Clinic examination. Okay.
Yeah,
Yes,
yeah,
sir.
yeah,
Go ahead.
yeah. So, as I have discussed, we will look for vitals, any focus of infection, anthropometry, look for any features of raised intracranial pressure, features suggestive of meningitis, especially if positive features, neurocutaneous marker, any dysmorphic faces such as broadening of nose, upturned nostril, or philtrum is prolonged, or antimoguloid slant, low set ears. They are the subtle dysmorphic features which we can look at. And then we look for focal neurological signs, Moro's reflex in neonatal period, and other reflexes. What are the red flags where we have to worry more? We have to be very cautious, and we have to investigate in detail. So common focal red flags are if the any child presenting to you with fever or seizure or fever with seizure, you first look for, after assessing his stability of vitals, look for focal neurological signs. Persistent altered sensorium even after 1 hour of seizure. Features of raised intracranial pressure such as headache, vomiting, papilledema, wrist and deep tendon reflexes, Cushing's triad, bradycardia, irregular respiration, and hypertension. Features suggestive of meningoencephalitis, non-blanching rash in an unwell child, and features of septic shock, sepsis, and respiratory distress. So these we call it as red flag signs. Next slide, please. Arpita, next slide. Yeah. So, if we take an algorithmic approach, how to go about the child from common problems, no red flags, to the child with red flags, how to go about, how to get differentiate between the sequence of activity which we have to perform while assessing child with seizure in presence of fever. So, any child comes to you uh, in your OPD or triage with the age of 6 months to 6 years with a feature of fever and seizure. We look for signs of meningoencephalitis, any serious infection, or head trauma. We exclude, and if there is anything in on these three lines, we exclude this child from fever with seizure, that is simple febrile seizure or complex febrile seizure. We deal this child appropriately with immediate intervention. If the child is not falling in this category, then we follow the child to, if the seizure is generalized tonic-clonic, duration is less than 15 minutes or more than 15 minutes, if there is no recurrence within 24 hours, or there are chances of multiple seizures, or there is incomplete recovery in first hour. So here we have got different and differentiated the child into simple febrile seizure where the duration is less than 15 minutes, where the recovery is complete, and other child who have a focal seizure duration is more than 15 minutes, or there is an incomplete recovery even after passing 1 hour post seizure episode. So, first category would be simple febrile seizure, other would be complex febrile seizure. Unless when we have found that the child is active, well, uh, playing around, so we call this child as a simple febrile seizure. We do not do further investigation. There is no role of lumbar puncture, complete blood count for TLC and differential count, C-reactive protein, electrolyte, magnesium, EEG, neuroimaging. So we usually don't do all this investigation unless there are uh, features suggestive of uh, having ambiguous features in comparison to a complex febrile seizure. So if there is a certain ambiguous feature, we do investigate. But if the child is completely well, then we counsel the family and we send the child home. So we counsel about the recurrence risk of the seizure, risk of epilepsy, rescue medication to be taken, intermittent and continuous prophylaxis, which are routinely not recommended. But if the parental anxiety is high, then we can add clobazam to the child. In contrast to this febrile seizure, we do investigate in a child coming to as features of complex febrile seizure. We send CBC, C-reactive protein, serum electrolyte. We do a blood glucose bedside. We consider lumbar puncture if there is a febrile status epilepsy, or antibiotic. We plan to start antibiotic. Then do a lumbar puncture if the situation is feasible, or the child is unvaccinated for H influenza B, pneumococcus vaccine, PCV vaccine, or the child has not recovered completely, then we do these investigation. We add calcium, iron if there are features suggestive of calcium or iron deficiency, and occasionally we send the child for MRI if the features suggestive of any brain injury. If the seizure episode is prolonged, there are focal seizures, and there is incomplete recovery, or there is a history of pre-existing delayed development. And in addition to these investigation, we look for the feature focus of fever as well. And when the child is stable, we do EEG. We counsel the family about the recurrence risk, epilepsy, rescue medication when we send the child home. We continue the prophylaxis with valproic acid in febrile status and existing delay, developmental delay. We can consider intermittent clobazam in if the family is highly anxious. For evaluating, as we have discussed, lumbar puncture in a simple febrile seizure, we usually don't do. If there are any features suggestive of meningitis, such as raised ICP or bulging anterior fontanelle, or the child is less than 12 months of age, and there is if there is any history of the child hasn't received any vaccination, especially H influenza B and pneumococcal vaccine, or child pre-treated with antibiotics where the antibiotics have improved the clinical condition, and we are not able to differentiate between partially treated meningitis or simple febrile season. If there is suspicion about it, then we do lumbar puncture to clear up the matter. Or if the child is having severe PEM, protein energy malnutrition, then we perform lumbar puncture in a case of simple febrile seizure. In a complex febrile seizure, we usually consider lumbar puncture. MRI is not recommended in simple. Sometimes we can do if the we have performed lumbar puncture and which has suggestive of partially treated meningitis, or there are any features of focal neurological deficit, then we do. And complex febrile seizure should be done preferably within 72 hours of presentation when a feature of to evaluate the feature of viral encephalitis, ADEM, or intracranial space occupying lesion, cortical malformation, or hippocampal abnormalities, or any feature suggestive of developmental delay. There is no indication of EEG in a simple febrile seizure, but yes, in complex febrile seizure, one must do EEG, uh, preferably after 48 hours of seizure episode. Now, with the availability of genetic test yeah, the, in are near, and the testing is also become cheaper now. So we should send a genetic test, whole genome sequencing or clinical genome sequences as the facilities are available to look for Dravet syndrome in recurrent febrile status epilepticus or prolonged hemiconvulsive seizures below the 1 year of age, or vaccine-associated encephalopathy, or GEF, GEFS plus. Uh, Next slide, Arpita. Next slide. Uh, Next slide. So, uh, as I have discussed, in simple, we don't see send CBC with CRP, not routinely, but in a complex situation, we send yes. Electrolyte, we don't send in simple, but yes in complex seizures. Serum calcium, if the child is less than 1 year, if the child is uh, more than 1 year, we don't send calcium in simple, but in complex, we send. Similarly, serum magnesium, we don't send anytime, but in a more than 1 year child or complex febrile seizure, we send magnesium. Blood sugar in a complex febrile child, serum iron, and urine analysis as the clinical condition suggests. The management of choice in a simple febrile seizure is we give a the drug of choice is intranasal midazolam. When we are using it as rescue medication, we give intranasally. The dose is zero point 0.2 to zero point 0.3 milligram per kg, maximum 5 milligram. Other effective drugs are IM or buccal midazolam, buccal lorazepam, and parectal diazepam. Maximum 2 doses can be given after interval of 5 minutes. Management of febrile status epilepticus at hospital is similar to the management of convulsive status epilepticus. So the algorithm for status epilepticus is similar to the algorithm of any convulsive status epileptic, where we have to do a ABC, airway breathing circulation stabilization, and we give midazolam, and then we escalate as per requirement. We stabilize ABCDE if the if the child is diagnosed with Dravet syndrome, febrile status, or plus one genetic epilepsy with febrile status or sodium channel blocker, phenytoin should be avoided. In children, in cases of clinical suspicion of meningitis, febrile status, and third generation cephalosporin, till the lumbar puncture is delayed. If we are there are features suggestive of meningitis, or features suggestive of partially treated meningitis, or there are features of complex febrile seizure. then should do lumbar puncture. If you are not able to perform lumbar puncture for any reason, we should give third generation cephalosporin and should go for neuroimaging. If we are able to perform
can uh, withhold uh, for half an hour. Next slide. Children with febrile seizure are prone to recurrence. There are slight increased risk of epilepsy in this population is the result of which is the result of genetic predisposition. There is no differential learning uh, in children with simple febrile seizure except in those children who have neurological abnormalities before this febrile seizure. There is negligible risk of child dying from the simple febrile seizure due to injury, aspiration, or cardiac arrhythmia. And successful treatment of simple febrile seizure can neither prevent later development of epilepsy nor simple febrile seizure can cause any structural damage to the brain. So, this has to be informed to the family uh, uh, while offering prophylaxis in form of clobazam. Possible adverse effect of prophylactic therapy include rare fatal hepatotoxicity, especially in children younger than 2 years, uh, who are especially at a greater risk of febrile seizure, thrombocytopenia, weight loss, weight gain, GI disturbances, pancreatitis with valproic acid, and hyperactivity, irritability, lethargy, sleep disturbance, and hypersensitivity reaction with phenobarbital, lethargy, drowsiness, ataxia with intermittent diazepam, as well as risk of masking and evolving CNS infection is also there. So when we use these prophylactic anti-epileptic drugs, there is the risk of masking CNS infection as well. Antipyretic and tablet sponging, if properly done, may improve the comfort of the child, but they do not prevent fever or febrile seizure. So this should be informed. Paracetamol in a dose of 15 milligram per kg per dose can be given up to can be repeated after 4 to 6 hourly. Uh, Few word about prophylaxis. Neither continuous nor intermittent anticonvulsive therapy is recommended for children with one or more simple febrile seizure, as there is preponderance of harm over benefit with therapy. Intermittent prophylaxis with oral benzodiazepine may be considered among children with frequent simple febrile seizure with parental anxiety. Re- Residence of the family is far from medical facility or complex febrile seizure who have not started on continuous prophylaxis. Continuous prophylaxis with anticonvulsant may be considered among children with febrile status epilepticus, febrile seizure in children with neurodevelopmental delay like cerebral palsy, global developmental delay, autism spectrum, ASD, autism spectrum disorder, frequent and complex febrile seizure, and children with febrile seizure and GEFS, genetic epilepsy with febrile seizure plus a disease with afebrile seizures. Next slide. Yeah. Uh, Next, further next. Yeah. The drug of choice for intermittent prophylaxis is clobazam with a dose of 0.5 to 1 milligram per kg per day in two divided doses for 3 days without tapering. Maximum dose is 20 milligram. The drug of choice for continuous prophylaxis is sodium valproate, 20 to 40 milligram per kg per day. Other is phenobarbital, primidone, carbamazepine, and phenytoin. These are two anti-epileptic drugs. They are ineffective in prophylaxis of febrile seizure. The anticonvulsant should be considered for 2 years freedom period or guided individually based on primary syndrome, such as in case of Dravet syndrome or genetic epilepsy with febrile seizure plus disease. Recurrence of febrile seizure. So this is about prognosis. 32% children have recurrent seizure, 17% have one recurrence, 9% have two recurrence, 6% have three or more recurrence. So this status we know that one third of all children having febrile seizure, two-third will not have any recurrence. 32%, that is one third, have recurrences, out of which 17% have one recurrence, 9% have two recurrence, and 6% has more than two recurrence, three or more recurrence. Recurrence rate within first year and second year of febrile seizure is 75% and 90% respectively. So around 75% children do have recurrence in within 1 year of first seizure. Risk factor for recurrent febrile seizure is early onset seizure, that is the first seizure episode is occurred in less than 18 months. Family history of febrile seizure or epilepsy in a first degree relative. Low grade fever associated seizure onset. If the child has seizure when the fever was not very high. Next slide. Arpita, next slide. Next slide. And if the family has short duration of fever before the precipitation of seizure episode. So if there is a short interval between the fever and precipitation of seizure is less than 1 hour, then there are chances the fever intensity, the person having seizure with the fever is of low grade fever, or there is family history, early onset seizure. So these are situation where there are higher chances of recurrence in comparison to the children which are not falling in these categories. Next slide. Children with febrile seizure have 1% risk of developing epilepsy by the age of 7 years, which is same as general population, and 2.4% by 25 years of age. So uh, when we look for the prognosis of epilepsy in long term, in a child with simple febrile seizure, the risk is 1%, which is a standard risk with it, which is same as in general population. So there is no increased risk of seizure in a child with simple febrile seizure. Children who have multiple simple febrile seizure are younger than 12 months of age at any time during the first febrile seizure and have a family history of epilepsy are at higher risk of epilepsy. So, who are at higher risk of having epilepsy in later life? More than 1%. That is the children who have multiple simple febrile seizure at younger age than when the child was less than 1 year of age, and if there is any family history or there are repeated febrile seizure. Risk of epilepsy after complex febrile seizure depends upon the number of complex features. When there is only one complex feature, 6 to 8%. When two complex features, it's 17 to 22%. And if there is more than two complex feature, there is 49, that is 50% chances of epilepsy. So when a child having physical features or uh, facial features suggestive of any abnormality, or there is developmental delay, or if there is seizure are more than 15 minutes, or the recovery time is more than 1 hour, then this child, if features are more than 3, then around 50, the child having uh, we can prognosticate that the child can have 50% chance having epilepsy in his later life. So here also we can remind them that there are 50% chance that the child will not have any seizure in his later life. Okay, thank you, Arpita. Next slide. Thank you, Arpita.
Thank you, sir. Thank you so much for the insightful talk. I would request all the audience who are with us, if you have any queries, kindly put it in the comment box so that I can read them out to sir and sir will be answering them. Right, sir. If time permits, can we take two, three questions from our audience?
Yeah.
Okay, sir. Okay. Let us see what are the questions that have come from our doctors. Sir, what is your recommended approach for managing recurrent febrile seizure in the absence of identifiable CNS infection?
So once we know that the seizure is of febrile onset, and the child is having the history of the child is asymptomatic, there is no developmental delay, or there is no history suggestive of any CNS insult during neonatal period, then we can counsel them that this is a febrile seizure, and there is very less chance that the child may turn up to the epilepsy in later life. And but if there are repeated febrile seizure, then we have to investigate with MRI with contrast, as well as uh, to look for the any features of Dravet syndrome or plus disease, so that we can counsel appropriately. Next question, please.
Yes, sir. There is another question from Dr. Bhupinder. He wants to know how reliable are biomarkers like CRP and procalcitonin in distinguishing febrile seizures from the CNS infection in emergency setting.
So in emergency, we don't have to have a very clarity at a very high precise point. If we feel that the child has a background history, if we feel that the child has received antibiotic in a community, if we feel that the child is looking not well, then we should rule out meningitis, because meningitis, not treating meningitis would be some sort of crime, because it can have a partially treated meningitis or untreated meningitis can uh, cause a significant damage to the brain. So we have to positively rule out if there is any suspicion over it. If the child is active, playful, appetite normal, uh, with a history of fever and seizure, so if all the things are in our in favor of child, then that child, in addition to the C-reactive protein and uh, PCT, normalcy of C-reactive protein as well as normalcy of procalcitonin. So we can let that child to without lumbar puncture or any neuro investigation, if we have any slightest iota of doubt to possibility of meningitis, we should positively rule out meningitis. Next slide.
Right, sir.
Oh,
One last query I will take. Sir, in cases where lumbar puncture is deferred initially, what monitoring protocol would you recommend in the first 24 hours?
so any situation where lumbar puncture is where men required is not able to perform because of parental anxiety, refusal of consent, uh, or the facilities available at the center is not there, then we should start antibiotic third generation cephalosporin, uh, especially if the child is not vaccinated for pneumococcal vaccine and influenza vaccine, then we should start antibiotic ceftriaxone and send a blood investigation. If they turn out to be normal, then we should give antibiotic for 7 days. If there is any abnormality, then we should give 10 to 14 days of antibiotic. uh, Nowadays, antibiotic, when the child is stable, can be given by mouth as well. Uh, it is not mandatory to continue give whole course of antibiotic with IV medication.
Right, sir. Thank you, sir. Thank you so much for answering all the queries. And before concluding the session, sir, I would like to take this opportunity to thank you for giving us your time, for sharing your knowledge, and for putting effort for making such a wonderful presentation. So, thank you so much, sir, on behalf of the IGCP team. Thank you.
Thank, thank you, Arpita.
Thanks
Thank
to all the Yes, sir.
you.
Thanks to all our esteemed doctors for joining for the sessions and putting your questions. It makes the session really engaging. Thank you all. With this, we are closing the session for today.